That was terrific. Dr. Jane, do you have any comments, reaction?
Yeah, so that was fantastic, and thank you very much, Bill. I would say if you have a chance to actually read those two reports, they're incredible. I think they provide a blueprint for policymakers to really think critically about a lot of these issues. Um, a couple of kind of points of reaction. I think one of my concerns about the increasing dialogue around high cost, high need patients, and I love that that has become a part of our vernacular, and I love that we're talking a lot about managing our most complex patients, is that I think we're not spending enough time thinking about how we actually prevent them from getting there. And so I think that there's a lot of dialogue around how do we take care of the sickest of the sick. There's not a lot of conversation around how do we actually prolong wellness so that they have peaceful deaths in the hands of great palliative care physicians and hospice care. I think it's a very concerning and confusing part of the dialogue because we have a fee-for-service system that is very generous in terms of reimbursing care for avoidable complications of chronic disease, and so that's an area of focus for policymakers that I think is really hard to put your hands around, which is why I think we haven't done it. I think there's an intuitive quality to we should just manage the sickest of the sick better, but I think there's a lot of work to be done on that kind of preventing progression of chronic disease. The second observation I want to make is one of about why we actually don't have the cross-sector innovation that we really need, and I'll share some observations from my time in government that I think will hopefully shed some light on some of the challenges that we face. Probably the most interesting delivery intervention that was studied, in the last 20 years from my perspective, was the NIH study of the diabetes prevention program. It was a large, well-controlled study that showed, without a doubt, that exercise or metformin could actually prevent progression from prediabetes to diabetes in a lot of different populations, but in particular, even the 60-plus population. I had the privilege of working at CMS at around, in the birth of the innovations, around the time of the birth of the Innovation Center, and I was blown away at our federal bureaucracy's failure to actually connect dots across agencies, and both of these agencies report up to a single secretary, CMS, the NIH. But when I was kind of probing, could we use data from an NIH-funded study that would never actually be repeated ever again, in the world, there was zero crosstalk between the NIH, CDC, and CMS around how do you actually accelerate the implementation of things that we know work into practice. And what the determination that was made was that we would actually have to restudy it at CMS under kind of CMMI's authorities, that we couldn't actually create those connection points. And so when we talk about now Medicare and Medicaid, so that's coordination between different agencies of HHS. Now we're talking about different divisions of CMS and the need to actually create a coordinating office. And there is a coordinating office, and I think it's done some really phenomenal work. But I'm going to blame Leonard here since he was the first administrator of HCFA. The federal infrastructure is not necessarily set up to actually create coordination, and so now we're talking about housing and urban development. We're talking about education, and we're talking about actually accounting for how interventions translate into results and create social good. And there's a long list of these things. If you're familiar with the nurse-family partnership, it actually prevents children from actually landing in special education classes, and you can create huge savings. So a healthcare intervention creates education savings, but we don't actually have a good way of accounting for that on a federal basis. And so I think we need to start changing how we think about health and how we talk about health. And when we write healthcare legislation, it probably shouldn't just be healthcare legislation, and it needs to explicitly write to the responsibilities of other agencies and explicitly prompt that cross-sector innovation, and explicitly prompt the structural reforms that are needed, within agencies. And I will say, as a former bureaucrat, we follow, legislation. I think the opportunities from a policy perspective are to actually, legislate and enforce the need for intra-agency collaboration as well as collaboration across agencies. And so I think that these problems are start with how we define the responsibilities of these agencies, and actually how we write legislation to actually solve these problems. So I would kind of end by just putting in a plug again for what we can do within the existing policy infrastructure. So there's we can continue to reform policy, but there's lots of things we can do within the existing structures. I think Landmark was created within the existing structure. The PACE programs were created. CareMore was created, and we're growing and we're scaling. And I would say we should look at organizations and try to figure out how we can enable them to do more of what they're doing. There's lots of great examples here. Final point, and kind of just backtracking a little bit, is around risk adjustment. This is critically important. Getting these formulas wrong can be the difference between killing all the organizations in this room and growing and enabling them. And this is an area where I think my former colleagues at CMS don't really realize the impact of changing a coefficient on a risk adjustment formula. It's the difference between being in business and being out of business. And in this time when we're actually trying to create more capacity in this space, I think there should be a little bit more laxity in the risk adjustment formulas, so that we do what Bill said, which is create an industry around actually serving these people. And CMS has a great history of creating the home health industry, creating ambulatory surgical centers. I think we need to go through a period where we are creating a lot of capacity. There need not be just 20 organizations or 10 organizations, and it's the same organizations at every one of these conferences, right? We really need to create 10,000 of them, and that's the next, I think, big surge in capacity that CMS needs to be thinking about, is how do we really create organizations that actually, solve these problems. So
that was terrific. Thank you. So I was struck by the fact that your report, the BPC report, calls for the allowing, I think the phrase was sort of not primarily healthcare related supports. And the Aspen Institute came out with a report recently with a similar call. And those are, two important entities. And I'm curious if what you see the barriers are to getting there. Is it health policy, or is it budget related? I mean, it may not be health policy. It may be a function of budgets and scores.
Well, being an old budgeteer, I think it probably starts with the budget. The fear that recognizing even if our analysis is correct, and even if you could provide those for services non-directly primary medical, whether it be Meals on Wheels or non-emergent transportation, those, if we even provided those, that probably means a $5 reduction in what other supplemental benefits could have been provided. So it is a budgetary issue that comes up. But my guess is, I've always had, and this is, you're the experts here. You know this better than I do. Dr. Bank knows this. I never quite understood why maybe we couldn't have hospice paid through the directly through, as opposed to a separate. Now, why not? Because it's very expensive. And as that one chart I put up to show you, the concern is that if we've got healthcare costs growing at 7% over the next annually over the next, that is an issue. I'd be the first one to admit that in the last 24 hours, I'm not sure the deficit matters anymore in this country, but that's okay too. So we can go forward with that.
So we've heard a lot of from innovators in the field on different programs that address different populations. I'm curious if either of you have some thoughts on which of those perhaps should be the first priority for congressional attention. Any of the models or any of the innovative programs we've heard today?
I'm a fan of the PACE program. I think the PACE program should be expanded. It was, as I understand, allowed. In fact, one of our recommendations that came to pass was expansion of for those under the age of 55. I think it should be a major program. It can be a model going forward. I do believe that the PACE program is a good, but what, it's 33,000 or something? It's hardly anything there and going forward.
So you guys mentioned something earlier that I don't want to let pass here, because you talked about risk adjustment and the severity of changes in that formula, especially to PACE programs, because I can tell you now, a small adjustment in that, we will close our doors, because we're on such a thin margin now. We're not making money at all. It's just trying to provide the services that we can to those communities. So my question to both of you is, how can CMS or our government push PACE programs to a encounter data reporting system away from risk adjustment? Because that's what they're sort of insinuating to us that they want PACE programs to do, is move to more of a fee-for-service kind of a reporting system and away from risk adjustment.
I mean, I think there's a fundamental lack of understanding of the care that's actually happening, and I mean, I'm just telling stories now because there are a lot of them in my head, but this is kind of maybe a few days before the final MSSP regulation went out the door, and one of the things I was asked to do was to write a memo documenting the triple aim outcomes of ACOs. And I said, but there are no ACOs. And they said, well, there are all these ACOs that are coming to see us. And I said, no, this regulation that we're introducing is to actually introduce the is to actually create the whole ACO industry. And it just was like one of these moments that just explained to me why we have these problems and why we need to get regulators out into the field. Because this, when you're within the Beltway, I think you don't fully get what you're doing when you're futzing with the risk adjustment formula, and it's why it's so important for people to come and tell these stories. I just think we need to kind of create more real world connection between federal agencies and bureaucrats and what's happening in the field. One of the things we've talked about today, and no one actually explicitly said this, but no one talked about hospitals today, and the fact that everyone implicitly in their policy prescriptions basically we're disintermediating hospitals, and once we want to manage patients in less costly outpatient settings and do that robustly. We need to have that conversation today. I just want to prompt that because I think that's an important part of what hasn't been said today.
Can I speak to that? That was what I was going to ask.
Yeah.
Because every program you heard about, whether it's my DSNP at CCA, whether it's Landmark, all these programs are simply diverting from the acute care setting, which provides expensive and often futile cost. And through my entire 10 years of doing this, there's been no plan about how to get hospitals engaged and responsible for population health, or at the very least, partnering with DSNPs, and again, at DSNP around OneCare in Massachusetts, we had to go back and redo the rates. It was acute care. It's when people hit acute care, they are financially incentivized to move patients in an opposite direction than any of the interventions here are. So I really wanted to pose that question. How does the payment policy and how do we structure this so that we have partners that are aligned at the acute care setting, which if you put up those numbers, my guess is 70 to 80% of that is acute care services. Thanks.
So I think some of it is actually creating a common bottom line with hospital partners. And I think that's something that, CareMore has been successful at doing, is actually creating, risk share agreements with hospital partners. So when those beds are filling, they're just as concerned about it as you are, and are thinking about, how you can actually better coordinate and manage care. And, in the absence of a common bottom line, I don't think you'll ever get there.
All right, well, I guess we're going to do questions and discussion from the audience. Over on that side.
So I'd like to thank our two panelists for ending the day on sort of an upbeat note and showing us some sunshine instead of that thunderstorm. I was going to ask you to kind of take your ideas on how policy can be molded either in Congress or at the agencies back into some to-dos for the people in this room who are, I think, really committed to the sorts of changes that Mr. Hoagland showed and Dr. Jain are talking about. Could each of you just give 3 quick bullet points? When you get back home, do the following 3 things to either ensure passage of the bills that Mr. Hoagland introduced, or for Dr. Jain to sort of get somebody working on making the risk adjustment formulas better. What can people in this room actually do?
I don't know if I have 3, but I want to.
5's fine.
Despite the perception of a non-functioning federal government, I guess I'm just still a farm boy from the Midwest that still believes in the system here. I still believe that you, particularly at the grassroots level, have the strongest say by bringing those members, those senators, bringing them to your operation, showing them what you're doing. But my one observation, and I realize this may be a little bit sensitive. I've heard today that this is going to be a challenge for publicly elected officials. I've heard that the way you're putting your program, some of these programs together, an earlier panelist discussed the models as having to show an ROI. And to me, that will connote for some of these members up here on the Hill that terrible situation of death panels, that we're saving money because of death. Dr. Jain talked about changing the culture out there, the way people think. We have to change the culture of the way these elected officials think about this issue. This is more than just death panels. What this is dignity at the end of life that they have to better understand. And I don't know how, we're changing culture all over, but this one really needs to change the culture of our elected officials.
So I'll give you 4, not 3 and not 5. So number 1, there's a lot of funders in the room today. So I would encourage you to fund a Dignity Palooza. The Health Data Palooza is a very well-funded industry event. I think there's a lot of funders in the room. I think we could do a lot to create, movement and momentum. I think there have been the Open Society Institute. There have been a lot of kind of academic type efforts. I'll call this an academic type effort. Reports get published, articles get published in big journals that never get read. I think we need to create a social movement around this, and it's going to take that evidence base to actually prompt that broader conversation. But there needs to be a social movement, and we need to start thinking like folks who are actually part of a social movement. Number 2, or start thinking like Ray Kroc, who took an idea from San Bernardino, California, and made it a national phenomenon, and not replicate some of his bad behavior. Number 2, recognizing that there's actually a lot of policy instruments that you could bring back to your organizations today, like MA. Medicare Advantage is not something that a lot of organizations are doing a lot with, but you can get 100% of premium dollar, today from CMS if you operate your own MA plan, which gives you a lot of freedom and flexibility to do things, and hopefully, Bill's report will be successful, and we'll even get more freedom and flexibility. But there's a lot of flexibility within MA, and there's a lot of organizations not taking advantage of that flexibility. So I think there's a real opportunity there. Number 3, you can start calling out incrementalism. One of the things I like to say at CareMore is that pilot is a 4-letter word, not a 5-letter word. Start calling out when your organizations are trying to pilot things that we know work. It's the most disgusting behavior we have in our industry, from reprehensible, disgusting, use your favorite word. I mean, We don't need to pilot things that we know work. You know, I see people retesting things that as a means of actually deferring real action, and we all participate in it, myself included. And we need to be honest about when we're kicking the can down the road on hard decisions and actually start making those hard decisions. And then, you know, finally, you know, with connection to this hospital conversation, we need to actually start having real, authentic conversations about winners and losers, and the fact that you know the language of value is all about win, 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 win. And the truth is that not everyone is going to win. If we start taking cost and waste out of the system, there will be some parts of the system that will shrink while others grow, and that is not a conversation that we are at all comfortable having, because we have these multi-stakeholder panels that with folks who represent multiple stakeholders, and it's unpopular to say that maybe we have 20% too many X, and it makes people uncomfortable, so that we don't ever say it. And when we don't say it, we actually don't define the problem in the way that the problem needs to be defined. And so if we're not getting the problem definition right, how the heck are we actually going to solve it? So those are my 4.
Thank you.
I'll give you a 5th one since you asked for it. The 5th is to actually start having conversations with an agency or an organization that feels like it's oblique to your core mission, and see if there's an opportunity to actually bridge a gap. You know, we're talking with the Red Cross. We're talking with you know, the local agency on aging, because we're really interested in the issue of senior loneliness and how we can partner to actually, you know, solve that problem. So I think having a non-traditional conversation is a 5th one. So.
On the right.
Thank you, and thank everyone on the panel. I thought the discussion has been excellent, but unfortunately I feel called upon by something that Dr. Jane said to sort of correct the record for you.
I was just first of all, I was just joking, and I was.
Well, you're yeah. I wouldn't go home at night without some armed assistance. But anyhow, so I was appointed the head of the Healthcare Financing Administration, which is now CMS, in 1978, before most of you were born. And when I left, everything was perfect. So whatever problems we're talking about now, it was screwed up by people who came after I did. I was the youngest serving, and I'm the oldest living administrator. But prior to that, I was the head of the Bureau of the Budget for the state of Illinois, and prior to that, I ran the Department of Mental Health in Illinois, which had, at that time, 22 hospitals and 24,000 inpatients. So I saw legislation. We're talking about policy prescriptions here at both the state and the federal level. And one of the things I would ask you all to think about is there's a big difference between what you know and what you're concerned about and what elected officials know and what they're concerned about. And basically, they don't know much about any of the things you know. I mean, not much at all, okay? Most healthcare legislation is a function of 3 things. Debates about 3 things. The first is money. Okay, healthcare is now 19% of the GDP. It is by far the fastest growing portion of the federal budget. Okay, the federal budget has only 4 pieces, and that is healthcare, Social Security, interest on the debt, and everything else. And everything else is becoming a smaller piece of the GDP. It's healthcare and soon interest on the debt that's driving everything. So when they talk about money, the question for legislators is who pays? If it's going to be government, how are we going to pay for it? Okay? The question for all the lobbyists is who gets the money? And if it's me, I think it's a great idea for you to vote yes. So it is overwhelmingly about money. The second thing that has driven healthcare in the United States is debates over the role of government. What is the appropriate role for government to play in our society? And unlike every other developed country, we haven't come to any conclusion. Every place else, just about every other developed country, there is some kind of a national healthcare plan. It usually has a budget that the government controls and some kind of financing that the government controls. we have this fantasy that we're a market economy, and somehow the market economy is going to fix it. So, for instance, on the question of shouldn't we cover transportation? Well, should government really pay for transportation? I mean, in this country, you ought to go out and get a job. You ought to have your own car. And if you can't afford a car, that's your problem, right? This is America. And believe me, there are elected officials who think that way. So what is the appropriate role of government? And what you don't want to do is walk into the elected official who tells you, as Thomas Jefferson said, that government which governs best governs least. I mean, they really believe that. The third thing is money, role of government, and the third thing is social values. And the oddest social values came in, and you just heard one. But I've never, ever been in a healthcare legislative debate where somebody didn't talk about abortion, even when you're talking about end of life. Okay, the other issue that will come up is this notion of social services. That's a social value. If you look at the United States versus every other developed country, we have the highest budget for healthcare, the lowest budget for social services, and the worst outcomes. And clearly, if you just, don't want to do it because socially that's inappropriate. It's not an American social value. So I want to go back over and cover my points, because first you tell them what you're going to tell them, then you tell them what you told them. I did a hell of a job at Hicks. It's about money, it's about the role of government, and it's about social values. Thank you very much.
Your comments remind me of somebody who recently said, who knew healthcare could be so complicated?
Jim,
I was just joking, Leonard. That's all I wanted to say. Just set the record straight. So.
Jim Middleberger, Optum Center for Palliative and Supportive Care. I want to appreciate that was one of the more heartening conversations coming, especially out of the Beltway, that I've heard in a while. I really appreciate it. I'd like to appreciate especially the idea of focusing and bringing functional status more clearly into the system. This may be a cost-neutral intervention, and I believe it might integrate, Dr. Jane, the preventive upstream interventions with the later stage interventions. And I'll add a few things as a hospice medical director in the past. Function is critical to prognosis. We have difficulty with the most sophisticated data systems in the world, actually healthcare data systems in the world, unless we have functional status. And we don't do good risk assessment with functional status. And so I want to appreciate that and maybe think how we can operationalize that in an even faster way. And I'd like to also call out some of the craziness in our system, in that every patient that passes through a nursing home gets a really comprehensive functional status assessment, but we can't get to it anywhere else in the healthcare system. It just sits there in a silo. So thank you. And how are you going to move faster to make this potentially cost-neutral intervention happen?
I'm speechless, partly because, quite frankly, I'm thinking of your comments earlier, what's the role of government in healthcare? And the debate that's going on up there right now suggests to you that we're nowhere close to resolving that issue, and I'm afraid it's going to continue on for some time given the partisan nature of the way Washington's operating right now. So I'm sorry, I don't have an answer how quickly we can move this. I hope it was.
I was going to let you just do 6 suggestions.
Well, I know Dr. Jane's got to leave early, so I want to leave you both with actually one question. We still have a minute or two. Let's say Secretary Price or Seema Verma gives you a call, wants to know what's the top thing he or she should be doing on community-based palliative care or issues around to improve quality of life for people who are near the end of life. What's your, not 5 or 6, what's your 1 or 2 suggestions?
I obviously have to stick to my the report for the bipartisan policy. The one that I would stick to is to expand the benefits in the MA plan to cover quote non-medical and keep it within that framework.
Yeah, I would be I would say the same thing actually, is to actually create maybe a mechanism through which MA plans or even folks who operate within fee-for-service Medicare could appeal to CMS to fund something that doesn't necessarily fit into a fee-for-service table. And so if you can justify or the need for X to help patient Y with something, that there is an opportunity for that to be considered.
Yeah, there's one direction of reform that we haven't really brought to the table, although it's present in every other developed country, and that is some degree of local management of at least the elder care and disabled service delivery systems. There was a smartphone here telling me they didn't know what I said. But in Washington, D.C., we have, at last count, 60 home care agencies that have to serve every home in D.C. So everybody has a 3.5-hour minimum, and there's a tremendous amount of windshield time in one of the smallest cities in the country. It seems that some degree of geographic provision of services, once they have to be in the home, and some degree of a feedback loop that would inform communities as to how they're doing, are directions that we haven't really touched on, and that might be very fertile. Might provide a way to, at least again for elders and disabled, maybe the 40-year-olds can fend for themselves. What do you think?
Good idea. I think it should be the next forum that you have here at the Academy.
All right, so if we're going to meet the Schaefer standard, I think this is a good time to end. We're under time. Thank you for the panel.